Okay, well, welcome everybody. Thank you so much for joining us this afternoon. I am very excited to introduce our grand round speaker today. We have Dr. Rachel Young with us. She is originally from Nebraska and made her way to the East Coast for her medical training, where she completed her medical degree at Harvard Medical School, her internal medicine residency at Beth Israel Deaconess Medical Center, and then she attended her medical oncology fellowship at Dana-Farber Cancer Institute, where she later joined as faculty. Her clinical and research interests have largely focused on breast cancer, cancer screening and prevention, and patient wellness. And in 2017, we were very lucky to have Dr. Young join the UW community as faculty with the Seattle Cancer Care Alliance. And she is currently an associate professor in the UW Department of Medical Oncology and the Clinical Research Division at Fred Hutch. She has many roles and leadership positions here at UW and SCCA. She's a practicing oncologist in breast cancer. She serves as the assistant director for the UW Hem-Onc Fellowship Program and is engaged in many oncology education programs within the IM residency as well. Dr. Young is the SCCA Director of Breast Prevention and Wellness, and she's also an active researcher in clinical breast cancer prevention and survivorship, and has a strong focus on healthcare disparities and health equity. She is a recent recipient of a very prestigious grant award from the American Cancer Society and Pfizer to address racial disparities within breast cancer. Dr. Young is not only an inspiring clinician and researcher, but I'm very, very fortunate to have been able to call her my own mentor during my time here at UW. And Dr. Young, I will turn it to you. I am so thrilled that you will get to join us today.
Thanks, Tess. That was really special. So I have titled my talk, Why We Can't Talk About Breast Cancer Without Talking About Racial Disparities. And I'm going to jump on in. So our motivation is really that a lot of women get breast cancer. 1 out of 8 women will get breast cancer in their life. That's about 13% of the population. Cancer is the leading cause of death for women ages 45 to 84. And it's the second leading cause of cancer death. And breast cancer mortality is 40% higher for Black women than for white women. And so my disclosures are these: that disparities can be a sensitive topic, that this talk will focus on the Black-white racial disparities, that I do this work because it's important, but recognize that I come with my own biases, that I've joined a larger team working toward excellent outcomes for women with breast cancer, and to please reach out to me with any feedback about this presentation or thoughts. And lastly, I have no financial conflicts. So this is that larger team that I was talking about. These are all folks that have participated in some way or another through this work and are continuing to lead efforts in this arena. I'll be calling people out throughout the presentation. But just such a great group. It makes me smile. So an overview, I'm going to do a little bit of a breast cancer primer so that we can understand what we're talking about. I'm going to talk about disparities in breast cancer. I'm going to talk about breast cancer screening. I'm going to talk about the disparities in Seattle and what our current efforts are at the University of Washington. So breast cancer general statistics. It's the most common cancer in women. It's over 250,000 cases every year, and it has the second highest cancer mortality in women, with 42,000 deaths in the United States annually. And just to give you a sense, there are 3 million survivors in the United States as of 2014, and that's about 4% of the population over 40. And the 5-year survival rate is 90%. Going a little bit deeper, in the vast majority of our new patients, we're really treating with curative intent, and that's because localized and regional disease makes up 93% of all breast cancer. Most patients who actually die of breast cancer have recurrent breast cancer, so somehow their treatment for their earlier stage breast cancer was not effective, and their cancer comes back. And for this presentation, I'm going to be primarily focusing on that non-metastatic disease. So this is what stage of diagnosis looks like by race. And I think it's really quite notable that we see that for localized disease, there's, in all of these, localized, regional, and distant, we see a Black-white difference, with less Black women being diagnosed with localized disease at 58% compared to 67% for white women. And this is why that matters, is because we know that survival varies by stage, and we see that in localized disease that the 5-year relative survival is almost 99%, whereas when it goes to regional disease, it drops to 86%, and for distant disease, it's much smaller at 28%. On the right, you see a graph that's just looking at survival over time based on these different stages. Then looking at the subtypes of breast cancer, what I want to draw your eye to here is that triple negative breast cancer tends to have the highest mortality, and you see that the percentage here is 77% compared to in the 90s for many of the others. And why that matters is because the rate of triple negative breast cancer is twice as high in non-Hispanic Black women. So both treatment and prognosis depend on the stage and subtype of cancer. So a couple of examples, and this is about as nitty-gritty as I'm going to get. So a 64-year-old with a screen-detected 1 centimeter ER-positive, HER2-negative breast cancer. This is a small, well-behaved breast cancer, and it's typically treated with surgery, radiation, and endocrine therapy without chemotherapy. And a 5-year risk of recurrence with all of that treatment is about 5%. Say in contrast, we're looking at a 42-year-old with a palpable 4 centimeter triple negative breast cancer. This is a much more large and aggressive cancer. It requires chemotherapy, surgery, and radiation. And the 5-year risk of recurrence is 25% with all those modalities. If someone were to decline chemotherapy, the risk of recurrence would be 50%. So breast cancer has a continuum of care, with really requiring multidisciplinary care through primary care, radiology, pathology, surgery, medical oncology, radiation oncology, social work, physical therapy, genetic counselors, and nutrition. And a timeline of active therapy varies from about 2 months to 2 years, and it's on average about a year of treatment. So racial disparities, what are they, where do they come from, and what might we do about it? So this describes what the incidence and mortality of breast cancer is. And I think it's notable that Black women actually have a slightly lower incidence of breast cancer than white women, but you see that they have a 40% higher mortality. And if we look over the years, we see that back in the 1970s, there was some equality in terms of mortality for Black and white women. But over the decades, and as treatment has become, both screening and treatment have become more widespread, we see that the disparities have increased significantly. So what are the disparities along the breast cancer care continuum? We know that those who have the most PCP access have a decreased mortality, that we see higher stage for Black women versus white women, that mammography rates are lower for Black women versus white women, and I'm going to be focusing a significant portion of the talk on this. Here in Seattle, our rates prior to COVID were 61% screened for Black women and 74% for white women. So we know that there's a delay to a diagnostic mammogram after an abnormal mammogram for Black women versus white women. That there are treatment delays. These treatment delays actually increase the risk of death. There's receipt of non-standard therapy, modified lower doses, not including anthracyclines, and not getting indicated chemotherapy. There's a decreased rate of definitive local therapy, and in particular radiation and breast conserving surgery. There's less endocrine therapy given, and that there's lower adherence, lower genetic testing rates, and that comorbidities, including obesity and other comorbidities, are higher, and we know that these actually influence the recurrence risk of breast cancer. So what actually affects this disparity the most? And this was a really nice study in the Journal of Clinical Oncology trying to get at what is the attribution of disparity based on this study. And what they found are that tumor characteristics made up part of this at 23%, that the stage of diagnosis was very important at 34%. In this study, they didn't find an effective treatment. However, I'd like to point out that this was both at NCCN sites, which tend to be sort of centers of clinical excellence. Also, when they looked at treatment, they didn't look at things such as non-standard therapy or delays to treatment. BMI influences the disparity, insurance type comorbidities, and together they were able to have an estimate of about 54% of why we see these disparities. I just want to say that disparities differ across states, across regions, but they exist everywhere. I put a little red arrow here to show Washington. And we are on the lower end, but I'd like to just point out that our mortality rate is still 23% higher here for Black women than white women. So this is a summary of the causes of disparity. We know that cancer biology does play into some of this, that there are higher rates of triple negative breast cancer, and there's a whole literature, and I'm happy to talk more about that as well. We know that epidemiology and screening practices may be different, and there may be potentially an intersection of these two, and I'm going to show that a little bit later. We know that there's stage migration, a lower adherence to standard of care with delays, misuse, and underuse of proven therapies. But there's increased comorbidity, and then there are social and structural factors. None of these is actually distinct, but may actually play into each other. So what are some solutions? I think one way to think about this is to focus on a particular time or transition point. And other things that we want to think about are efforts across the continuum, building trust in the community, bringing this to light, increasing the number of people working on it, and partnering to decrease disparities across other diseases. So I'm going to start at the beginning and really thinking about the breast cancer care continuum, and we're going to be thinking about prevention and screening in particular. So breast cancer early detection, breast cancer is a screenable cancer. So we know that mammograms save lives by finding cancer before it's appreciated by feel or appearance. The mortality has decreased with screening, and that guidelines are conflicting and recent changes may be somewhat confusing. So mammography screening guidelines and controversy. These give some of the major institutions, the USPSTF, ACS, ACR, NCCN, and discuss what the recommendations are at these different age ranges. What we see is that the USPSTF has the sort of minimal recommendations, and that is what many institutions have adopted as their institutional standard. I would point out that this assumes that all of these patients are at average risk. So anybody who's at high risk should actually be encouraged to receive mammography on a different time scale. Sometimes I think it can be difficult to assess what average risk patients are. The other thing that I'll say is that it is very difficult to measure discussion in a quality metric. And so at this point in time, all of our quality metrics are really limited to those above 50 years of age. And then my last point is just that this may influence sort of preventative care services in terms of who's actually feeling like they need to come to the doctor and what services they need to have. So how did we get here? This is a table actually out of the USPSTF article that makes a recommendation for using 50 to 74. And these are the data that they're looking at. So if you are to screen biennially, so every other year, for 100 women screened, these are the results that we would say if we were looking at 40 to 74-year-olds versus 50 to 74-year-olds, we would save one extra life by screening those younger women, but we actually increase the number of life years gained by about 25%. So it goes from 122 to 152. This is at the risk of false positives, which increase significantly, unnecessary breast biopsies, which also increase notably. And I sort of dispute the overdiagnosis because I think in the younger years that this is hard to actually account for. So, and this is where we get to intent versus impact. So what are the guideline recommendations and what are the potential effects? So I'm just going to bring up some of the epidemiology. This is the incidence of breast cancer by age and race. And I'm just pointing out what the age or the box of those who are sort of in this controversial or gray area is. And we see in this population or in this age range that the incidence of breast cancer is significantly higher in Black women than it is in white women. And when we look at breast cancer mortality by age and race, we see that it's increased at all age ranges, but I think notably in these younger women, we think about both their incidence and then mortality and years lost. And this is depicted very nicely by this article from ACS with their guideline recommendations that really show that, and I've again pointed out this 45 to 49 year group of women, incidence really starts going up at 45 years of age. The mortality is quite significant. And if you actually look at the number of years of life lost, it is highest in those who are diagnosed between 45 and 49 years of age. So a couple of key points on mammography and some summary of recommendations. The mammography saves lives. We know that it saves 7 to 8 women per 1,000 women screened. That's really important. That from 50 to 75 years of age, that this is really undisputed and that the minimum recommendation is every 2 years. And that between 40 and 49 years of age, that there's a little bit of controversy. There's, it's intended that there should be a discussion. But I'll suggest that maybe this is potentially a missed opportunity. And with the data that I just showed, I worry that it may worsen disparity. So where are we now? So these are screening rates in the UW primary care clinics. I've blurred it out because of confidentiality, but each of these boxes is a clinic and the size is proportional to the number of women in that clinic within this age range. And this is only looking to see if women have had appropriate screening in the last 2 years. And red is bad and green is good. And you'll see for white women that there are many more green blocks than there are for Black women of this same age range. When we looked at rates pre-COVID, the screening rates for white women were 74%, and for Black women, it was 61%. We all know that COVID decreased a lot of preventative care and maintenance efforts. And more currently, the rates for white women are 70%, and for Black women, it's 58%. So this is just a map sort of demonstrating where the Black population in King County is by percentage. And I'd like to just point out that much of this is sort of south of South Lake Union. And then this is the University of Washington's mammography. So we have 4 brick and mortar sites. It's South Lake Union, SCCA, Roosevelt, Eastside, and Northwest Hospital. And then we have the mammogram van that services other areas. And I think it is notable to see that most of our brick and mortar sites do sort of center around our main campuses. The mammogram site or van does go all the way down south to Federal Way. So ongoing efforts at the University of Washington. So I am so pleased and excited that the health equity goal for fiscal years 21, and then it was extended for 2022, were to decrease disparities in breast cancer screening. And as part of this, an equity committee was formed. So the co-leads here are Dr. Feng and Dr. Houston. And you can see that it includes a very large multidisciplinary community, including diversity leadership, primary care, population health, Harborview, UWMC, community advisors, women's health, OBGYN, breast medical oncology, breast imaging, value-based care, process improvement, and analytics. And I say all of those in part because it has been really important and critical that we have had all of these players at the table in order to really discuss what are the underlying barriers and how do we break through those. So what our goals were or are to reach a goal of the 75th percentile, which is approximately 75% screening rates for the BIPOC community, and to decrease the disparity index to 1, just meaning that Black women have the same rates as white women, even if we're not able to make it to that 75th percentile. And our initial focus was really on the Black and African American women with a disparity index goal of decreasing it to 1.25. And some of our projects include cross-entity collaborations, and I'm going to describe a few: our health equity dashboard, a website review, an analysis of supply and demand, looking at scheduling barriers, community outreach, and then we've been able to secure multiple grants as part of this larger effort. So this is an equity dashboard, and this is a tool that you all can get access to through AMC. You just have to get your access to Tableau. And it allows us to screen by race and ethnicity and look at the rates of breast cancer screening over time. So we see that in the bottom range. I'd like to just bring up that this is for all of UW Medicine, that for the American Indian and Alaskan Native, that the rate of screening is 55% at the point in time when this was looked at. For Black and African American, it was 57%. For Hispanic women, it was 66%. And for white women, it was 70%. Additionally, there was a PAFIP grant that was given to these wonderful women. And the aim was really to build a patient-centered web-based tool to support breast cancer screening outreach in Black communities. And what they did was 21 qualitative interviews and IT development. And what they found when they did those qualitative interviews were that barriers were better described. There was a lack of resources in terms of cost transportation, conflicts with work, anxiety about what to expect, worry about pain, prior negative experiences, a lack of clear recommendations from primary care, lack or advocacy or lack thereof from primary care, time spent to make the appointment, time until the appointments, and a need for reminders. And the intervention was this prototype of SCCA chatbot. And you see here that it has both sort of chatting functionality as well as maps and scheduling functionality. Still a work in process, but really great movement forward. And then we were able to, and I say we in the larger sense, these are grants that were given or won by a group at Seattle Cancer Alliance, Cancer Care Alliance, and then the University of Washington Primary Care. And it was very strategic that we applied for both of these grants so that we could really double our efforts to try to get women back into screening after we saw that initial drop off from COVID. And from lessons learned, in particular from COVID vaccinations, we had folks come and talk to us. We really wanted to focus on these groups that had already experienced disparities. And so as part of the ACS Return to Screening grant from SCCA, we were able to hire a program coordinator. This is Gabrielle Flowers. She's a wonderful lifelong Seattle resident who has worked in mammography scheduling for the last 5 years and really understands the ins and outs of how mammography is scheduled and has a deep passion to help her community in this process. And so she's able to do patient connections, scheduling support, collaboration with primary care navigation, identification and removal of barriers to care, targeted outreach. And then as part of this, we are also doing some translation of educational material and offering some transportation support. On the other hand, the Primary Care Award is really a targeted outreach to Black and African American women. There was some culturally cognizant informational flyers that have been made, and then really an outreach of many different multitudes, thinking about using letters and postcards and mailed outreach, text messaging outreach, a navigator-based phone outreach, and then support for empanelment and navigation of benefits and screening. And all of these are critical. And we really are working together because we don't want women to be getting calls from lots of different people. And so it's critical that we're working together to make sure that women are getting the best approach possible. And then this is the ACS grant that Tess brought up. This is a breast health equity grant. The goal is in this lofty effort to decrease breast cancer mortality excess in Black women. And this is a grant that has a data gathering section, an intervention section, and goals. And in the data gathering, I'm going to describe these a little bit more. We're looking at the UW dashboard and a database derived information. We're doing community interviews. And then we're doing clinic interviews, QI analysis, and systems-based work. And the interventions are really sort of thinking about patient-directed, patient and community-directed interventions versus system-based and provider-directed. And our goals are very similar to those stated for the overall health equity goal to exceed 75% screening, to decrease disparity and to decrease the disparity index. And then the other aspect that we're really looking for is sustainability. So using the UW data to determine the at-risk populations, and I'm just going to highlight because we have so many talented people in our group, in UW's medicine group, that I want to highlight work that's being done. So Tess is working on patient level risk factors and looking at sociodemographics, comorbidities, healthcare utilization and access, and other cancer screenings to understand who these women are and can we capture them in that sort of way. And Anisha is working on a systems-based analysis, more looking at the workflow, patient characteristics, when's the mammogram ordered, if it's scheduled and completed, diagnostic imaging, how the results are communicated, and really what that time frame is. Then we also are planning or starting our community intervention or outreach, and prior qualitative research in this space has showed that barriers to screening and perspectives on breast cancer include a mistrust of medicine and actually the government in general, a mistrust of physician intent and concern about pharmaceutical influence, and then logistical barriers and access to care. We wanted to know what it looks like right here in Seattle and if there are any other particular issues that women are experiencing. And so as part of that, we have brought Bridget Hempstead on board. She is the founder of CIERRA Sisters and one of our community consultants. And we are doing interviews for women who are over 40, who've never had a mammogram or behind, have lapsed in their screening. And we are actively searching for participants right now. So please feel free to refer people to us. You may see these flyers up throughout the neighborhood clinics. And we're really looking to ask questions about their beliefs and attitudes, their knowledge, their experience and behaviors, and then we'll be going back to them to understand what interventions would potentially work for them. And this is just a call out to Bridget and her organization, which is CIERRA Sisters, which was founded a number of decades ago and really serves as a support for initially it was sort of Black and African American women, but really has expanded to the BIPOC community. And Bridget is a real trusted member in the community and a treasured resource for us in this process. Additionally, we have just recently been working on partnering with Ethnomed and community house calls, and are working with Anab and Yodit, as well as Leanne and Christine, to look at the non-English speaking population and find out what this community, what the community voices look like there. And so Anisha, with the support of Anab and Yodit, was able to essentially rework our interview guide to be more culturally appropriate, and we are working to get this out to women. It'll be going to the IRB really shortly. And so some proven interventions to improve breast cancer screening. So we know that there are things that have worked in the past, such as patient-directed things like reminder-based interventions. And we know that culturally tailored interventions can be very important. So classroom education, videos, education with nurse practitioners, and then multifaceted interventions. So really thinking about how do we get people there in terms of all the barriers that exist. So mammogram vouchers and transportation, childcare support, appointment scheduling, and then coupled with provider advice. On the provider-directed end, these have oftentimes been sort of more effective and yet have a ceiling effect. So being able to get physician chart reminders in place, feedback on compliance, other strategies such as this. But oftentimes what this does is improves our rates within our empaneled population, but may not actually cover the entire population that we're actually sort of caring for or serving for. And so some proposed strategies to improve screening, and many of these we've actually already initiated, are patient-directed and then systems-based. In regards to reminder-based interventions or things about scheduling, along with Epic Go Live D1, during that, it was initiated that women could self-schedule for mammography. Additionally, the neighborhood clinics, several of the neighborhood clinics have been taught how to do this scheduling and are able to support women when they're there for other appointments. You can think about small media campaigns, and we look towards our community conversations to understand where the best and how the best way to go about that is. In terms of education, we are talking about COVID support, but the other aspect here is that the COVID vaccine team at SCCA and the Fred Hutch has made really great partnerships with the community, and they are asking for more support in terms of this. This is actually has allowed us that on October 17th, the mammogram van is going to be going to one of the churches in South Seattle to provide mammography, and we will have a scheduler there as well. We really need to address the idea of mistrust, and I'm going to speak to this a little bit later. really with an improvement to diversify our providers and partner with our community organizations. And then thinking about other ideas. So within Ethnomed, there is already a video that looks at or that helps explain breast cancer screening in Somalian. But it seems to have, it doesn't appear that it is widely used. And so I think what we need to do is go back and find out how we can modify these interventions that we already have to make them more useful. And then in terms of systems-based interventions, we are working on just making sure that the availability matches the need, working on IT solutions, navigator-based solutions, and in particular using the neighborhood clinics navigators, as well as Gabrielle Flowers sitting at SCCA to be able to help with that. And then working on provider-based education and feedback. And then the other aspect that we're hoping to do is really catching people at any touch point and working to empanel women so that we can sort of hold on to them and help them get through this process. So again, this is blurred out a little bit. These are clinics that I hope to target with interventions. I have talked to people in most of these clinics. However, if you see yourself or you practice at one of these clinics and you have an interest in this and you have ideas, please feel free to reach out to me. I would love to hear what you have to say, and I'll probably be reaching out to your group soon. And I'm going to go through some of the systems-based issues that we have been working on. This is looking at more that the clinic-based issue, and this was work done by 3 of the residents a year and a half ago, and it really was just looking at what it takes to actually have a mammogram completed in our system. And what we see is that, you know, is this a wellness visit? Yes, no. Essentially, if it's no, pretty much people come to this stop sign. They're not going to have any discussion about a mammogram at that point in time. So it really is through wellness appointments, and then it requires a lot of steps, you see, to be able to get to the place where a mammogram is actually complete in the yellow circle. And so another way that we're thinking about QI intervention, I was able to talk to the Harborview Medical Center group of doctors. And as part of that, we identified multiple barriers. So the mammogram van is only there on Thursdays, which you can imagine causes issues for patients who come in on other days. That staff were not aware that the mammogram van was available in all of the different neighborhoods. That the mammogram van is not currently ADA accessible, and that's something that we are getting a new mammogram van, and it will have better accessibility. So that is hopefully going to break down that barrier. There continue to be logistical and financial barriers, that there are overwhelming clinical demands within the clinic, which makes it hard to approach those preventative care issues, and that there was a need for more supported outreach that we hope to be able to provide. And then I'm going to just tell a little bit of a story about this last issue, which is that bills were sent to patients who were supposed to have coverage. And so as I started this work, this was kind of an apocryphal story that I heard, that women were getting bills and that it was breeding mistrust in the community and also with providers. And when I went and spoke to the community or to the clinic, I was able to hear that providers had, yes, indeed, had this experience, that their patients had had this experience, and that they themselves had had it enough times that they were even hesitant about sort of feeling confident that they could tell women that they were going to have coverage. And in particular, this has to do with Harborview charity care coverage, that we have a reciprocal agreement at SCCA that this would be covered. And as part of all of this work, we had this multidisciplinary group of people already at the ready. And we said, who do we need to have on this conversation? How do we seek this out? How do we get these answers? And we were able to get a subgroup of people together were able to indeed sort out that the process of making sure that that coverage got translated so that they didn't have a bill sent to them actually was requiring 2 sets of manual information pulls. So it required a pull from the scheduler at the time of scheduling the mammogram, and then it required a pull on the other end, on the rev cycle end, to be able to take pull those patients and have their bills released or what have you. We recognize that that system is just broken, and that it is never going to be a good system to have two sets of manual extractions. Giovanna and Gabrielle have worked to put in a request for this to be automated so that this would happen essentially automatically. In the meantime, we have full awareness over this issue, and we are working on reparations to make sure that women who've had issues in the past have reparations about this. And this has happened just in the last couple of weeks, but I have to say that being able to get to the bottom of this issue that has spread sort of like wildfire in the communities feels good. I realize that we are very much on the very beginning part of that, and that we really need to think about how we're going to build that trust back up in the community. And it's a point to say that some of this work it's not glamorous. It's actually kind of ugly at times, but I think that it's important work, and that it's these pieces that have to be taken into account for us to really be able to address these disparities. And in that vein, I'm going to say that there's one other thing that we've been working on, and we hashtag this nowrongfrontdoor. And so this is something that came up. So self-referral for mammography is allowed by law in Washington state, but most organizations here in Seattle still require patients to have a PCP listed. And the reason why is because there's a goal to make sure that if there's an abnormal exam, that women are followed up on, right? That we can find them, that we know how to get a hold of them. And then also that it requires a provider order for diagnostic imaging. So if there is an abnormal image, that we need a provider to be able to do this or sign off to do diagnostic imaging. And so again, with our current multidisciplinary effort, we have ongoing to address this issue and try to reduce the barrier. So we're really trying to measure the extent of this issue, understand the flow and process to get to a PCP, and get one established, and then work on solutions to decrease the barriers. So this is definitely a work in progress. We're in the middle of our meetings, but I bring it up again because these are issues that could not be addressed, I think, by any single person. And it's really taken this multidisciplinary group to be able to step back and understand each aspect from their view. So I'm just going to put out a call for partners. We also have a primary care breast cancer sort of partnership that I'm trying to develop, but really we're looking for to develop relationships with primary care and others that want to serve as partners. Just like to put in a plug, the cancer patients are great. The patients are often motivated, that they have teachable moments. There's this idea of post-traumatic growth, and they're oftentimes looking for engaged PCPs. So if you have an interest in breast cancer screening, taking care of breast cancer survivors, please reach out to me. I'd love to talk with you. There's my email. And future directions. So I think within general medicine and the health equity work group, that work is going to continue. And some of the conversations that we've had is, how do we expand this to the whole BIPOC community? And then how do we work toward other health issues such as colon cancer screening, cervical cancer screening, hypertension, diabetes, et cetera. And then as a medical oncologist, I think about how I'm going to expand this work to the continuum of breast cancer care. And so really thinking about across that continuum, how do we improve the spectrum of breast cancer care, with many ideas here listed. And in summary, Black women have a 40% higher breast cancer mortality than white women. The disparities exist across the continuum of breast cancer care, from diagnosis through survivorship, that there are many layers to reduce disparities. I pose a question: should we think about breast cancer screening recommendations differently by race? And I've had some great conversations already about this. And that collective efforts are ongoing, and please reach out to myself or any of those on the health equity group if you want to be involved. And just to say that there are lots of resources available. As a breast cancer doctor, I definitely want you to know in terms of the prevention and breast health side of it. We have a breast health clinic. We have our breast ovarian cancer prevention program, which focuses on our highest risk folks usually with a cancer mutation. And we have genetics, and really we would encourage people to refer patients in if you have any questions. I also love to answer personal emails, and so welcome anyone to give me or send me a message if they have a particular question or want to know how to be tied into services better. And a plug, so Bridget is working with CIERRA Sisters and putting on a World Mammography Day. So this is happening on October 16th at Holy Temple Evangelist Center in Renton. And there are going to be COVID vaccines available, and there will be guest speakers, and it will be wonderful. And I just wanted to put that plug in for our community events. I think that's it. With gratitude, all of these folks.
That's great. Thank you so much, Dr. Young. I want to just encourage everybody to please feel free to put questions in the chat, and I'm happy to moderate any Q&A for the rest of our time. Before we do that, I wanted to ask one question, since I know there are probably many people practicing in different spaces and clinics. For the mammogram van, how could people go about knowing that schedule or getting patients connected to that resource?
Yes, the schedule is just online. I'm pretty sure that you can just Google mammogram van SCCA and find the schedule, but I'm also happy to get you the link and send it to you and have it connected to the recording.
Perfect, thank you. And then our first question comes, let's see. The message is saying, this is a great talk, such important work, and a question about how did you get started in this important area within breast cancer research, and in particular in the health equity piece?
Yeah, I think it happened a little bit organically. This is something that I've always had an interest in terms of thinking about quality and disparities and equity. And what this kind of came out of was really that there was a women's population health group that got together, and we started brainstorming about what we wanted to focus on. And screening came up as one of the ideas that we could look at. And through looking at the dashboard, which showed such significant differences in our population, we saw that this was a space that there was opportunity for us to make important strides forward on. And in that setting, sort of a lot of things happened all at the same time in terms of a grant opportunity and then development of the equity work group, and that this was named as an equity goal for the University of Washington. So it's been wonderful. And I have to say that really, I can't say the multidisciplinary part of it enough, that really this is something that I think that as people hear about it, that there's just been such excitement from all sorts of realms in terms of, the Fred Hutch got excited about it, and then having our COVID team hear about the work that we were doing, and they actually approached us and said, we've been doing these COVID vaccinations. They are asking for support for cancer screening. Can we do this? And so I think that really it's just been really an organic process of reaching out. People are excited about doing this kind of work.
That's great. Our next question, I think, is really interesting in thinking about the screening piece, and then the next step beyond that. Dr. Young is asking if you could just talk a little bit about the challenges regarding follow-up after screening for any cases where there are positive findings, and what your thoughts are on what work needs to be done in that space.
Yeah, this is a great question. And I think that we have had a number of successes. So this has been something that has been challenging. And we in breast cancer like to think about breast cancer screening as that whole episode. We talk about it as an episode of care, and really thinking about screening and diagnostic imaging when indicated as that whole episode of care. One issue is that most insurances will pay for screening imaging, and that typically has little or no copay. However, diagnostic imaging is not always covered by insurance companies. And so this can cause, and it's also is difficult to get sponsored funds for. So this can be a difficult aspect in terms of insurance sort of discontinuity from a screening mammogram to a diagnostic mammogram. Part of the reason why most institutions do require having a primary care doctor is because also it requires a separate provider to put in the order. So a radiologist cannot write an order for a test that they will perform, because that's considered insurance fraud. And so this needs to come from outside of the radiology suite. There are issues in terms of scheduling. So there are some inherent differences. So diagnostic imaging is only done at our brick and mortar sites. It's not done in the mammogram van. And so anyone who has their screening imaging done in the mammogram van will have to schedule for diagnostic imaging at one of the brick and mortar sites. Additionally, so I'm going to go to some of the good things that have happened. So along with Epic Go Live, there's actually a little, it has allowed radiology to essentially send the order to the provider that allows us to just move forward with diagnostic imaging at that time and place. And hopefully that will reduce the time between initial screening mammography and diagnostic mammography. So I could go on for a while, but I think that hits many of the issues.
And then a question that I think you kind of alluded to at the end of your talk, but this idea of breaking down screening recommendations by race, and maybe just thinking even among people who are at average risk, but perhaps there's obviously a wide array of gray area in that average space. Can you just maybe speak to any efforts or potential changes coming down the pike about any of those screening guidelines? And then the second part would be, how you might recommend talking to patients about those guidelines based on race or sort of disparities that we know do exist.
Yeah, this is a very complicated conversation, and it's part of the reason why we actually are including 40-year-olds in the conversation in our community interviews, because we really want to understand how people see their risk and what would be acceptable in terms of having frank conversations about race and epidemiology when you're thinking about breast cancer screening. I think that that's important. I'll say that the USPSTF, if you actually read the manuscript, they sort of have this very small paragraph where they say, yeah, we thought about race, but it's pretty small, and I feel pretty dismissive. I have heard in the community that there may be some changes moving forward, and that this may be something where we see different recommendations come out from the USPSTF, in particular, I think, surrounding this issue of race and potentially increasing racial disparities.
Okay, thank you so much. I will maybe give another minute for people to put in some more questions, but there are several comments thanking you for the talk and for your efforts in this area as well.
It's great. I do open it up, my emails on multiple things, but it's just ryoung@uw.edu. I'm happy to really talk about any of these issues, and I want to serve as a resource for sort of breast health and breast cancer care, from prevention all the way through survivorship. So if people have a question for me, I may not be able to answer it for you, but I am happy to try to connect you to the right person. So please use me as a resource in this community.
Amazing. Thank you so much, Dr. Young. This has been great.
Yeah, wonderful. Thank you so much.
Take care.
Bye-bye.
Thank you so much, everybody, for joining. Have a nice afternoon.